Hey there, Dr. Avinash here. This video is going to be about two important chapters from gastrointestinal system. One is going to be anti-emetics, and the next part of this video is going to be about anti-peptic ulcer drugs. Now, before we go on to the medicines, let's have a look at some basic things. Why do we vomit? Because we have a center called as the vomiting center located in the medulla oblongata. Okay, this is near the fourth ventricle. Okay, the medulla oblongata has this vomiting center which, when stimulated, can send efferent messages and cause a series of reactions that will eventually lead to vomiting. Chemoreceptor trigger zone and the nucleus tractus solitarius are the afferent regions of this entire system. The chemoreceptor trigger zone and the nucleus tractus solitarius know when to vomit. They are the ones which identify substances present in the blood. They are the centers where neurotransmitters are released whenever somebody has to vomit, and they directly stimulate the vomiting center. Actually, chemoreceptor trigger zone can tell the nucleus tractus solitarius to stimulate the vomiting center and cause vomiting. VX is vomiting. Simple. Now, of course, this is bilateral. I'm just drawing one side, but this is present on right side and left side both. Which chemicals stimulate chemoreceptor trigger zone? See, vomiting center we see is like the effector. You stimulate that, there will be vomiting. Who's understanding the need for vomiting? Chemoreceptor trigger zone and NTS, nucleus tractus solitarius. Which chemicals, which compounds can stimulate chemoreceptor trigger zone and nucleus tractus solitarius? Well, the compounds or the chemicals or the neurotransmitters that stimulate nucleus tractus solitarius are 5-HT, that's serotonin. It acts on the 5-HT3 receptor. Dopamine acting on D2 receptor. Muscarinic receptors are present, so of course acetylcholine will work here. Histamine works here on H1 receptor, and then we have NK1. Okay, NK1. NK means neurokinin. So neurokinins stimulate the neurokinin receptor 1 and can cause vomiting by acting on the nucleus tractus solitarius. Whereas in the chemoreceptor trigger zone, it's the neurokinin on its receptor number 1, dopamine at its D2 receptor, serotonin at its 5-HT3 receptor, plus there are mu receptors for opioids, and cannabinoid receptor 1 is also present. Now, why am I telling you all this? Is because if you can make a drug that blocks 5-HT3, vomiting will stop. If you block D2 receptors, vomiting will stop. If you block the neurokinin 1 receptor, vomiting will stop. If you block the histamine receptor number 1, vomiting will stop. If you block mu or CB1 receptor or muscarinic receptor, vomiting will stop. Well, there's one way by which vomiting happens. This happens because of activation of our vestibular apparatus. Now, the vestibular apparatus somehow gets connected to the cerebellum, and in that pathway, vomiting center gets stimulated. We exactly don't know which neurotransmitters are responsible here. We also know the fact that vomiting is partially a subjective phenomena. You might have noticed that some of the students in the first year during dissection, the very first day of dissection, started feeling pukey by just looking at the dead bodies lying on the anatomy dissection table, right? And some of us were very chilled out with the fact that, okay, they are dead bodies, big deal, right? So some things, of course, are at the level of your mind, at the level of your brain, the cerebral cortex. When you think it is repulsive enough, the brain can send a message directly to the vomiting center and cause vomiting. But what we are interested in is the vomiting that happens because of problems of the GIT also. If you eat something wrong, if there's infection inside the GIT, then what happens? Well, irritations, chemotherapy, radiotherapy, many medications, many infections, they cause damage to the intestinal epithelial cells, and as a result, serotonin, 5-HT, serotonin is made. This serotonin acts on the nervous tissue present inside the intestine and stimulates them. Getting it? So serotonin works on the receptors of the nerves present in the intestine and sends a message to the NTS and CTZ. The receptor at the level of intestine is also 5-HT3 receptor. Well, there's one more way things can happen. Serotonin can diffuse into blood, and from blood it can reach the chemoreceptor trigger zone. It can't reach nucleus tractus solitarius because chemoreceptor trigger zone is much more in contact with blood vessels. So everything in the blood can actually reach chemoreceptor trigger zone if given sufficient concentration. So two ways by which serotonin can work: via local nerves right till the brain, 5-HT3 receptors at the level of GIT. You block them, the message will not go to NTS and CTZ, no vomiting will happen. And at the level of CTZ, 5-HT3 receptors are there. So serotonin might reach the CTZ via blood. There's one more way though: inflammation. When GIT is inflamed, prostaglandins and some kinins are made. These prostaglandins and kinins enter into the blood. In the blood, they meet platelets. Prostaglandins and kinins act on the platelet. The platelets release serotonin. The serotonin is carried via the blood into chemoreceptor trigger zone, and that causes vomiting. If you have understood this particular slide, trust me, 50% job is done. So when I talk about anti-emetic drugs, you already know what you're going to do. Block the 5-HT3 receptors, block the neurokinin 1 receptor, block the dopamine D2 receptor, block the H1 H1 receptors, histamine receptors, block the muscarinic receptors. See, look at what is given on the slide. Block the M receptors, anticholinergics, hyoscine and dicyclomine. Block the H1 receptors, H1 antihistaminics, promethazine, diphenhydramine, dimenhydrinate, doxylamine, meclozine and cinnarizine. Block the D2 receptors, dopamine D2 receptors, neuroleptics such as chlorpromazine, triflupromazine and prochlorperazine, also haloperidol. Block the serotonin 3 receptors, 5-HT3 antagonist, ondansetron, granisetron, palonosetron and ramosetron. Block the NK1 receptors, NK1 receptor antagonist, aprepitant and phosaprepitant. Well, let's combine a few actions. Prokinetic, make the intestine move in such a way that there is nothing to vomit. Empty the stomach. Metoclopramide, domperidone, cisapride, mozapride, itopride. And then some adjuvant ones which are important as far as the classification goes, but we are never going to use them in day-to-day routine clinical practice: benzodiazepines, dronabinol and nabilone. So the classification can just be understood if you remember this. Easy it is, really easy. Let's talk about individual categories. Let's talk about H1 antihistaminics first. Why did I not talk about hyoscine and dicyclomine? We have already discussed it in ANS. So H1 antihistaminics are usually used for motion sickness. H1 antihistaminic don't just have antihistaminic properties, they are also anticholinergic and sedative. And when you are sleeping, you really can't vomit, right? There are three important drugs here: promethazine, diphenhydramine and dimenhydrinate. They have a similar action duration, that's 4 to 6 hours. You can combine them with metoclopramide. The combination is rational. We will talk about that later on when we talk about metoclopramide, okay? And we will understand this reason, blocking extrapyramidal side effects of metoclopramide by its anticholinergic action. We'll talk about that. Okay, right now just remember, H1 antihistaminics can be combined with metoclopramide, and that combination is rational because H1 antihistaminics prevent some side effects, extrapyramidal side effects of metoclopramide. The side effects are because of this antihistaminic, anticholinergic and sedative properties. Like the anticholinergic properties gives dry mouth, the sedative of course is sedation. So a person who has taken an antihistaminic is not fit for driving any vehicle. Let's talk about the other important drug of this category, that is doxylamine. This is a sedative. It also has a prominent anticholinergic activity, but important MCQ, if you combine this with pyridoxine, it is amazing drug for morning sickness. There are side effects though: sedation, it's drowsiness, anticholinergic, dry mouth, and sometimes people get vertigo because of it. Other people have reported abdominal upset. So the preferred time would be bedtime. At bedtime, if you are like sedated, that's even better. You will sleep better, right? That's the logic behind giving it bedtime. Other drugs are meclizine, way less sedative, less anticholinergic, and hence better. MCQ, meclizine is the drug of choice for seasickness, and even better, one tablet, 24-hour protection. Works best. Cinnarizine is actually an anti-vertigo, anti-motion sickness drug. This not only is antihistaminic, these are MCQs I am talking, none of this is a short answer, okay? It inhibits influx of calcium from the endolymph and somehow blocks those, giddiness feeling coming from the vestibular receptors. And that decreases the chances of vomiting. All these medicines have to be taken before the travel starts. Once that feeling of nausea sets in, then you can't stop the vomiting. Let's go on to dopamine receptor blockers, neuroleptics, D2 receptor blockers. They block D2 receptors in the chemoreceptor trigger zone. So there's this medicine called as apomorphine. Apomorphine causes vomiting. By acting on the D2 receptor, you give neuroleptics, the D2 action of apomorphine is blocked, vomiting stops. So it antagonizes apomorphine-induced vomiting. Many of them also have anti-muscarinic and H1 antihistaminic properties. Neuroleptics are actually psychotropic drugs. They are used for brain disorders. They are not that effective in motion sickness. Plus, there are side effects. Sedation. Some drugs cause muscle dystonia. So why will we use them? Nonetheless, let us look at the MCQ perspective of neuroleptics as antiemetics. Prochlorperazine. This suppresses the labyrinth, the balance apparatus in our ears. It is suppressed, so the brain does not get imbalanced messages, and as a result, the vomiting does not happen. So this works selectively as anti-vertigo plus antiemetic. Important MCQs, please remember all of these. The only problem with prochlorperazine is it causes muscle dystonia, especially in children. So be careful. Plus, dopamine receptor is blocked. Imagine we have learned an entire chapter on a disease because of dopamine not being there in the brain. Right? Parkinsonism. What is Parkinsonism? Extrapyramidal effects because of lack of dopamine in the brain. You're giving a medicine that blocks the action of dopamine. Don't you think you will get extrapyramidal side effects? That is exactly what will happen. So these are the limiting effects, That's why we don't love to give neuroleptics. And antihistaminics are much more complicated, like sedative also, antimuscarinic also, so many things. Why don't we give a prokinetic drug? We love this category. This includes metoclopramide, the drug which has been asked as an LAQ, the drug that you probably are going to prescribe very frequently in your clinical practice. It works on the GIT by increasing the gastric peristalsis. It's a prokinetic. It enhances peristalsis. It relaxes the pylorus. It relaxes the first part of duodenum. So the stomach becomes empty and the food is pushed down in the small intestine. See, food is not there in the stomach. How will you vomit, right? This action, prokinetic action, is better if there is an intact vagus nerve. See, we will go to final year subject surgery. And when we talk about surgery, there is a surgery called as vagotomy. We cut the vagus nerve in certain conditions like peptic ulcers. In those people who do not have vagus nerve, these medicines don't work that great. But metoclopramide works better in patients who have their vagus nerve working. Now, remember where it is working. In the stomach and the duodenum, not on the colon, not on the secretion. So don't expect metoclopramide to be given and loose motions will start. No, that is not going to happen. This drug cannot be used as a prokinetic for colon. No. Simple. Well, it also acts on the CNS and acts directly on the chemoreceptor trigger zone. It's not neuroleptic. It's not a drug that can control emotions and feelings and stuff like that, but it has similar effect, similar side effect pattern. Like prolactin secretion is increased. So guys can get breast, gynecomastia. Guys and girls both can start milk secretion. Galactorrhea can happen because of prolactin. and the extrapyramidal Parkinson-like symptoms can happen. So how does this work? Metoclopramide has multiple ways of working. The first is by inhibiting dopamine. The D2 receptor is blocked. Now D2 receptor not in the chemoreceptor trigger zone, that is blocked only. D2 receptor even in the GIT is blocked. Dopamine in GIT is inhibitory. Dopamine in GIT reduces peristalsis. Dopamine in GIT closes the pyloric sphincter. You block dopamine, the pyloric sphincter will open, the stomach will empty. Normally dopamine delays gastric emptying. Normally dopamine dilates the stomach and relaxes the lower esophageal sphincter. LES is lower esophageal sphincter. Before vomiting, that is supposed to happen. Stomach should dilate, lower esophageal sphincter should relax. That's when vomiting starts. You give metoclopramide, both these actions will be blocked. Plus, metoclopramide enhances acetylcholine release. By blocking dopamine, acetylcholine secretion increases inside the GIT, because of which peristalsis becomes better. Not only does it block dopamine at the level of GIT, it acts at the dopamine receptor 2 at CTZ, and that's how it can also act like a direct antiemetic. Remember, I said not just one method, it stimulates the 5-HT4 receptor. 5-HT4 receptor is serotonin receptor number 4. When this receptor is stimulated inside the nerves of the GIT, the myenteric motor neurons, the muscle of the GIT has its own nervous system. It's called as the myenteric motor plexus. That is stimulated to release what? Acetylcholine. And acetylcholine causes contractions in the stomach. It's called as gastric hurrying. Stomach empties, lower esophageal sphincter tightens. And the third way by which metoclopramide works is by 5-HT3 antagonism. It blocks the receptors on the inhibitory myenteric interneurons. So by blocking the inhibitory myenteric interneurons, it is enhancing peristalsis, plus it is also blocking 5-HT3 receptors in nucleus tractus solitarius and chemoreceptor trigger zone. Amazing, like so many actions. Definitely vomiting will stop. Now, metoclopramide, if given orally, acts within half an hour to 1 hour. It's pretty fast in its onset of action. If it's given intramuscularly, 10 minutes, and if given IV, within 2 minutes, the action will start becoming evident. The action lasts only for 4 to 6 hours, so repeated dosings might be necessary. But the problem is the side effects. Look at all the receptor it blocks. It's known to cause sedation, dizziness, loose motions, and muscle dystonias. It is known to cause drug-induced Parkinsonism. And remember, when dopamine is prolactin inhibiting substance, right? If dopamine receptor is blocked, you get galactorrhea and gynecomastia. Nonetheless, we use this for different types of vomiting, like post-operative vomiting, drug-induced vomiting, migraine or other disease-associated vomiting, radiation sickness. It's not that good for motion sickness. The combination of promethazine diphenhydramine is rational combination with metoclopramide. The logic behind this is promethazine or diphenhydramine are centrally acting anticholinergics, and when given with metoclopramide, they will prevent that extrapyramidal side effect, the Parkinsonism, the galactorrhea, that all things will be prevented. Simple, easy, logical. Achha. Apart from this, sometimes we want the peristalsis in the stomach to increase. So you can use this medicine as a gastrokinetic medication. Okay, now a gastrokinetic would be increasing the peristalsis in the GIT, in the let's say stomach and first part of the duodenum. Now, why would we use this kind of a medicine? Imagine a person who has eaten something and has to now undergo some emergency procedure for which general anesthesia is required. So when emergency general anesthesia is required, you want empty stomach, right? Give this, the stomach will become empty, right? The second would be post vagotomy, or sometimes diabetic patient get gastroparesis. The stomach kind of stops working. The efficacy is not 100%, but still works. Apart from this, we can give it for dyspepsia and other functional GI disorders such as intractable or persistent hiccups. Works pretty good. Symptomatic relief is definitely obtained. And lastly, we can even use it for gastrointestinal reflux disease, because it kind of pushes all the food downwards, so there is nothing left to reflux. Actually, it is not as effective as proton pump inhibitors and the H2 receptor blockers that we are going to study in the next chapter, but nonetheless, you need to know that metoclopramide can be used in GERD. Simple. Another prokinetic drug that you need to do as a short answer is domperidone. The brand name is Domstal, pretty famous. It's a D2 antagonist at the upper GIT level. And because it only works at the upper GI level, not in the brain, very less in the brain, the extrapyramidal side effects are rare. Hyperprolactinemia is known to happen, but the rest of the side effects are rare. It does act on chemoreceptor trigger zone. Compared to metoclopramide, its efficacy is lower, and there's only 15% bioavailability. Domperidone can be given with levodopa or bromocriptine in Parkinsonism. This combination is a very rational combination. Okay. The logic is levodopa sometimes has a nauseating effect, like emetic action is there, which is dose limiting levodopa's action. When you give domperidone along with levodopa, its entry into CNS is poor, right? So domperidone will not block the therapeutic effect of levodopa, but will stop the emetic action of levodopa. Clear? Now, apart from this, you also need to know some side effects. The side effects are cardiac arrhythmias, and this happens especially on IV injection. And the other side effects which are not really worth mentioning, like giving in writing, is dry mouth can happen, loose motions, headaches sometimes happen. People have complained of rashes and galactorrhea, but they are generally mild. Okay. Domperidone is for mild to moderate cases of post-operative drug and disease-induced nausea, vomiting. This is not for severe cases and not for motion sickness also. Okay. So not for motion sickness, not for even in severe cases. Just remember this much, more than sufficient. Now I am giving you some MCQs related to cisapride and the next drug. Cisapride, this is a potential short answer though. This can come as a surprise. It's a 5-HT4 agonist. 5-HT4 agonist. It shows weak 5-HT3 antagonism. Plus, it also promotes cyclic AMP dependent chloride secretion in the colon. There's no action on chemoreceptor trigger zone, no extrapyramidal side effects, no hyperprolactinemia, decent bioavailability of around 33%. The reason why we can give cisapride is GERD and conditions called as non-ulcer dyspepsia, impaired gastric emptying, and chronic constipation. The reason why cisapride is so important as MCQs is because cisapride at high concentration blocks a specific channel called as the delayed rectifying potassium channel. This prolongs the QTC interval on an ECG, and that predisposes to torsidicity pointus or ventricular fibrillation. Torsidicity pointus is a type of arrhythmia. Another drug is itopride. D2 antidopaminergic, anticholinergic, but low 5-HT4 blocker. This is unlikely to cause arrhythmias, and this is metabolized by flavin monooxygenase, not by cytochrome P450. The salient side effects of itopride: diarrhea, abdominal pain, and headaches. Because this has D2 antidopaminergic action, gynecomastia and galactorrhea can also happen. Now, domperidone or Domstal, that's a short answer. Metoclopramide is a potential long answer. In your textbooks, Mosapride has been highlighted. It is just like cisapride. Okay, the only difference between cisapride and mosapride does not have that prolonging QT interval, and as a result, it's safe from arrhythmias. Okay, itopride is not really available in India as of now. I don't think so. It was basically in Japan that they made it, and it was not available in US or UK for pretty long period of time. So these are the only additional things that you have to do. I think they have also mentioned a levosulpiride. That's only for MCQ. The second potential LAQ from this chapter is ondansetron. It is 5-HT3 antagonist. What does it do? It blocks the depolarizing action on vagus afferent. Vagal afferents are the ones which were carrying messages from the GIT to the chemoreceptor trigger zone and the nucleus tractus solitarius. So messages from the GIT don't reach NTS and CTZ. Receptors in the NTS and CTZ are blocked, but it does not have any action on dopamine or motion sickness induced vomiting. Basically, it has very little gastrokinetic action. So it's not a gastrokinetic agent. It's not a prokinetic. This can be given with dexamethasone and or promethazine and diazepam. Now the combination that I am mentioning is not for everyone. Sometimes there are some patients who do not obtain optimum protection by ondansetron alone. And in them, you might have to add either dexamethasone, promethazine or diazepam, or sometimes both. But nowadays even dexamethasone plus neurokinin receptor 1 antagonist have also been added, and they work very good in the delayed phase vomiting of cisplatin therapy. So this is good combination for those who are undergoing chemotherapy. Okay, the side effects include headache, constipation, diarrhea, abdominal discomfort, some rash. The use is very simple. Post chemotherapy vomiting, that's the best use of ondansetron, but it is less effective in post operative vomiting or drug induced vomiting. Now before I go on to the chapter for peptic ulcer, let me also tell you that the chapter in your textbooks also have aprepitant and fosaprepitant. I would recommend you have a look at aprepitant. Okay, might not really come in your exam, but this might come handy in case some odd questions do arise. Okay, your textbook also mentions about some digestins and gallstone dissolving agents, but they are not important. We don't use them in clinical practice that often, and there's hardly any rationale for that, so you can skip that part. Moving on to drugs for peptic ulcer. Now this is very, very, very important. The drug for peptic ulcer. To understand drugs for peptic ulcer, you have to understand the way by which acid is synthesized in our GIT, in our stomach. Okay, so let us talk about the acid preparation. I am talking about, of course, the parietal cells. They are responsible for making HCl. In the parietal cells, carbon dioxide react with water. This forms H2CO3, right? H2CO3 can split into H plus and HCO3 minus. This H plus is our H in HCl. Getting it? So this H plus has to go out, and for that we have a special pump called as the proton pump. This is an active transport pump. It takes H plus from within the cell and throws it out, and it takes potassium from outside the cell and brings it in. So the H plus of HCl is now done. It's in the lumen. Now let's talk about the chloride. At the basal membrane of this parietal cell, there is a special exchange transporter called as the bicarbonate chloride exchanger. HCO3 minus is given to the blood. In return, chloride enters the parietal cell, and that chloride simply diffuses out. H plus and Cl minus react with each other in the lumen to form HCl. HCl is not really made inside the parietal cell. I hope this is clear. This is the easy part. Let's come to the even more easier part. Who controls this proton pump? Who controls the parietal cell? Well, there are three distinct substances which can control this parietal cell and make it do the job of secreting HCl. These include acetylcholine by action on M3 receptor, gastrin by its action on gastrin receptor, and histamine, the green box, acting via H2 receptor. Now the question in our mind should be, where did histamine, gastrin and M3 come from? And if they are stimulating the parietal cell, is there anyone who can inhibit it? Yes. Prostaglandins, especially prostaglandin E1 via its receptor, can inhibit acid secretion. So one prostaglandin E1 for inhibition and three different compounds, acetylcholine, gastrin and H-histamine for secretion. Out of these three, histamine is the star performer. It does maximum activity of parietal cells. It activates the parietal cells to the maximum, to put it correctly. Where did this H-histamine come from? It came from a cell specialized to make histamine. It is lying nearby in the submucosa. This cell is called as histaminocyte, histamine secreting cell. When the stimulus is correct, histamine is released by the histaminocyte. The histamine then binds to H2 receptor and acid production starts. The question in the mind now should be, who controls the histaminocyte? Well, gastrin, it's a local hormone, can control histaminocyte. Well, gastrin can also directly cause parietal cells to make HCl, but it's more powerful if it works via histamine, because who's the star performer? Histamine. Gastrin can make acid, not as much as histamine can. So G cell, the gastrin cell, makes gastrin. Gastrin can either directly bind to parietal cell, create a little acid, or it can bind to the histaminocyte. Histaminocyte will make histamine. Histamine will bind to H2 receptor, and there will be massive increase in acid production. Simple. Another way by which histaminocyte can be stimulated is vagus nerve. The vagus nerve is of course going to release acetylcholine, and the acetylcholine can stimulate the histaminocyte. The histaminocyte releases histamine. Histamine binds to H2 receptor, and there will be massive increase in acid synthesis. But vagus nerve can also directly stimulate the parietal cell via M3 receptor. Now, just by looking at this particular slide, don't you think if we can make something that is anti-M3, the acid production will decrease? Of course. So we have drugs called as anticholinergics, which do exactly that. Can we make something against gastrin? Well, logically we can. Practically we have not been able to block the gastrin receptor, so chuck it. Can we block the can we block the histaminocyte? Well, we can't block the histaminocyte, but we can block the H2 receptor. That would be a significant decrease in acid production, because the star performer is the H2 receptor and histamine. But just because it's a star performer does not mean it's the only performer. There are M3 receptors, there's gastrin receptors. So even if you make a medicine that blocks the H2 receptor, some acid will be made. You know what you can do to completely block acid? Block the proton pump. Simple. And then we also have a medicine that can work like prostaglandin, which will reduce the acid secretion. So just by looking at this one diagram, we have now understood the mechanism of most of the medicines. Let us now understand the idea behind peptic ulcer. The worst thing that you can do right now is to think peptic ulcers are caused because of acidity. No. In your GIT, in your stomach, there are some damaging factors present which have the potential to destroy the mucosa. These are HCl and peptic enzymes, pepsin. But they fail. You know why they fail? Because we have defensive forces also, like the mucus. The mucus has bicarbonate in it. If acid tries to come in, it will be neutralized. The blood flow to the mucus membrane is amazing. The mucosal blood flow provides this constant supply of bicarbonate and of course water and other compounds, because of which good mucus is made. The apical surface has a good membrane transport, which means all these bicarbonates and H plus and all these compounds are thrown out in the mucus without damaging the mucosal cells. And in case the epithelium does get damaged, it's an epithelium with amazing regenerative capacity. It will regenerate. And should the time come when the acidity overpowers the mucus, prostaglandins will stop the acid secretion and protect the stomach. So normally in you and me, it's the defensive forces which are winning and the damaging forces which are losing. Unfortunately, people love to add more damaging forces in the form of H. pylori infection, non-steroidal anti-inflammatory drugs, aspirin, cigarettes, alcohol, or even duodeноgastric reflux. That can destroy mucus. Mucus gone, mucosa is going to get damaged. Think about decreasing defensive forces because of ischemia, shock. Maybe it's a genetic host problem. Nothing much can be done in that case. Or there is delayed gastric emptying. So the food remains for a longer period of time in the stomach. And the longer something remains in stomach, the greater the chance that the mucus will get destroyed. Worst case scenario, eventually the damaging forces win. There is a breach in the continuity of surface epithelium, which is called as an ulcer. And ulcers are dangerous because they not only bleed in the GIT, they can perforate through and through, causing peritonitis, and that can actually lead to so massive hemorrhage that people can die because of ulcers. So we have to be careful. We also have to be careful about this fact that it's not only about damaging and injuring factors. This bacteria called as Helicobacter pylori, with its ability to create ammonia, with its ability to digest mucus, with its ability to damage the epithelial cells, is implicated in the causation of peptic ulcer disease. So if you treat a guy with peptic ulcer and he recurs and you treat it again and it comes back again, you need to think about H. pylori. More details about H. pylori and how to manage that in your medicine textbook. That's not the point of discussion here, but we need to know some medicines that can kill this bacteria. And looking at that diagram, and now that we know that H. pylori is an important thing, let us talk about the potential drugs we have. Well, we can have H2 antihistaminics, proton pump inhibitors, anticholinergics, prostaglandin analogs. We can have antacids, which are going to act quick, neutralize the stomach acid, some ulcer protectives, and anti-H. pylori medications. Simple classification, very easy to remember. Now, as far as we are concerned, we are going to discuss H2 antihistaminics and PPIs, proton pump inhibitors. The rest of the questions are very rare questions, and for anti-H. pylori, you need to just do a table from the chapter. So there is nothing much to learn in the remaining thing. Just two important questions here. Cimetidine, ranitidine, and omeprazole would be the more important questions. So let's talk about H2 antagonist, histamine receptor number 2 antagonist, cimetidine, ranitidine, famotidine, roxatidine. There are many more. Out of these four, cimetidine, ranitidine, and roxatidine are competitive inhibitors of H2 receptor, whereas famotidine is competitive, non-competitive. Well, they block four important things. Histamine-induced gastric secretion is blocked. Histamine-induced cardiac stimulation is blocked. Histamine-induced uterine relaxation is blocked, and bronchial relaxation is blocked. By acting on H2 antagonist, right? It's an H2 antagonist that will block that receptor. Simple. Now, histamine-induced gastric secretion suppresses the nighttime production of acid completely. The basal nocturnal secretion of HCl is completely stopped. Let's talk about the salient feature of each one of them. Cimetidine, you give it orally, 60 to 80% finally makes its way to the blood. That is its bioavailability. If you give 100 mg tablet, if 60 to 80 mg appears in blood, that is 60 to 80% bioavailability. And the best part is, give it with food, without food, doesn't matter. Cimetidine is absorbed nonetheless, not interfered by food. The problem is it can cross the placenta, it can cross milk, it does not cross the blood-brain barrier. So the babies are at risk, but not the brain. It is eliminated by a T-half of 2 to 3 hours. And if the patient has kidney issues, you need to reduce the dose. Cimetidine will have some salient side effects. Headache and dizziness is one of them. Some people get bowel upset, others get dry mouth, some get rash. If it somehow works on the brain, confusions, restlessness, convulsions and coma are very frequent. You give cimetidine IV bolus, this itself has a capacity to release histamine, so be very careful. Give slow infusion. Cimetidine is also anti-androgenic, which means if you give to guys for a long period of time, they will start becoming girly. And lastly, there is a transient liver damage. It appears like liver is getting damaged because there's elevation of plasma aminotransferases. SGOT, SGPT, or as they love to call it AST, ALT nowadays, aspartate transaminase and alanine transaminase, their levels rise, which means the liver is getting a little damaged. Ranitidine, on the other hand, is 5 times more potent. It is non-anti-androgenic, it has no CNS effect, and the AST, ALT remains normal in these people. They ask you a question, what is the difference between cimetidine and ranitidine? You need to write these 4 points. Make a table, elaborate and give some description. Don't just write it. Give something extra points, 1 or 2 more, and then give 4 differences on each side, and it should work wonders. Famotidine MCQ has a thiazole ring and has inverse agonistic action. This is 5 to 8 times more potent than cimetidine, and it also is non-anti-androgenic. More importantly, it does not have cytochrome P450 interaction. It does not get broken by that enzyme. It is not going to be acting on that enzyme. Famotidine, we love to use it for Zollinger-Ellison syndrome, ZE syndrome. Zollinger-Ellison syndrome is the cancer of the head of the pancreas, which makes too much of gastrin. And that gastrin causes hyperacidity. In cases where you want to prevent aspiration pneumonia, imagine a patient who is comatose, drowsy, and you don't want him to puke and inhale that puke. Then you can give famotidine, works wonders. These medicines have to be used in cases of duodenal ulcers and gastric ulcers. Okay. Now, what's the difference between duodenal ulcer and gastric ulcer? Of course, duodenal ulcer is in the duodenum, gastric ulcer is in the stomach. The characteristic feature of gastric ulcer is that when the patient eats food, it starts to pain. Logical, right? You eat the food, the pyloric sphincter closes, the lower esophageal sphincter closes because the food is now supposed to be digested in the stomach. So you close both the doors, and what do? Add acid to the food. So when you eat the food, acidity increases in the stomach, right? 2 doors close and acidity increases, pain will increase. But imagine duodenal ulcer, the patient eats the food, the doors close, lower esophageal sphincter closes and pyloric sphincter closes, right? If pyloric sphincter closes, no acid from the stomach will reach the duodenum, getting it. That's the reason why the patient says, when I eat food, the pain decreases. But after 2 to 5 hours, when the pyloric sphincter will open, the acid starts coming into the duodenum. He says, I start feeling pain 2 to 5 hours after eating food. Mostly, gastric ulcer present with vomiting blood, hematemesis, or dark tarry stools which point to a GIT bleeding. Duodenal ulcer can present with melena, that's GIT bleeding, black tarry stools, or with hematochezia, that is frank blood in stools. Gastric ulcers usually present as chest discomfort, early satiety, heartburn, whereas duodenal ulcers don't have these complaints. Gastric ulcers can become gastric cancer, especially in elderly. And duodenal ulcer, see, what do? We eat food at, let's say, 8 o'clock. By 10 o'clock, 11 o'clock, we are sleeping, right? When does the pain start? 2 to 5 hours after eating, right? So will the patient be able to sleep? No. So duodenal ulcer will classically present with not being able to sleep in the night because of pain. For both these conditions, if you decrease the amount of acid, the pain will also decrease. You can even give it for stress ulcers and gastritis. Good drug. Please go through the textbook. You need to write, give some content. Just understand the things here, but write extra in your exam. ZE syndrome, I already explained, a tumor that makes gastrin. And it can be used for GERD, gastroesophageal reflux disease. Simple, easy. Because when the acid decreases, the burning sensation in the esophagus will stop, right? Which brings me to the second important, before I go there, one more point we missed out, 1 or 2 points. We can prevent aspiration pneumonia and management of urticaria. These are additional points that you can write. The second important medicine that you have to know is PPIs, proton pump inhibitors, omeprazole. This is important. This is very, very important. Omeprazole chemically is a substituted benzimidazole. Just remember this. They are so powerful that they block the final common pathway. They block the proton pump. Then you can make histamine, gastrin, M3 receptor, acetylcholine, nothing will work. Proton pump is blocked. Now, how does it work? Now, this is how it works. Now, this works long cut. When you give this medicine, it goes into the stomach, it goes into the intestine, and intestine absorb this medicine. Clear? Once it gets absorbed in the intestine, it enters into the blood. Once in the blood, it spreads throughout the body. Once it is spreading throughout the body, it is secreted at the basal membrane, somewhere here, of the gastric epithelial cells, here, on this line, on the lower side, the basal. Here, it is then secreted in the mucus. See how much long cut process is there. Get absorbed, go into the blood, come back, go out, back into the mucus. Now, if the acid in the stomach is there, pH is less than 5, then the molecules of omeprazole rearrange themselves in such a manner that two charged cationic forms are formed. One is a sulfanilic acid, the second is a sulfonamide configuration. These two then react with the proton pump. The proton pump has sulfhydryl group, SH group, sulfhydryl group, sulfur hydrogen groups, and they bind to it and irreversibly inactivate it. So it's kind of long cut, but it's irreversible blockade. Don't give it with food. If you give with food, the bioavailability decreases. They should be taken empty stomach, 1 hour before a meal or 2 or 3 hours after meal. Omeprazole is plasma protein bound, which means it will be a longer acting. Once it starts acting on the proton pump, the inhibition of HCl secretion starts within 1 hour. It becomes maximum at 2 hours. Even after 24 hours, 50% proton pumps are still inhibited, and the action on an average lasts around 3 days. So it's a very long acting drug. There is some fear though that if you block acid so much, then the body will try to overcompensate, right? Body does not want no acid. You as doctor wants no acid. Body will try to make acid by releasing more gastrin. So there is a fear that there will be compensatory hypergastrinemia, which does happen, and some doctors were worried this might cause cancers, gastrinomas, but that has not happened. The good news is the uses are exactly the same as beta blockers, H2 receptor blockers. So same you can write here. Simple, easy till now. I hope so. Okay. Now, what I'm going to do for you is give some important MCQs regarding other PPIs, proton pump inhibitors. S-omeprazole. This is the S-enantiomer. It is structurally different than omeprazole and it has a better bioavailability. Lansoprazole is much more potent as compared to omeprazole, and it is partially reversible inhibitor. But all the others are irreversible, and you need to lower the dose of lansoprazole in liver disease. Pantoprazole is kind of the most famous, PAN 20, PAN 40. More acid stable, better bioavailability, and the best part, IV formulation is available, which is not there with the others. And pantoprazole has minimum drug interactions, so that's good. This S-pantoprazole, more potent, twice as potent as pantoprazole, and rabeprazole MCQ. Rabeprazole has the fastest acid suppression. So there you have it, everything that you needed to know as far as anti-emetics and anti-peptic ulcer drugs are concerned. This brings us to the end of this session. Thanks for attending it. If you have any doubts, please feel free to ask. I will be more than happy to help you. Till the next time we meet, this is Dr. Avinash signing off for now. Take care, keep studying and keep rocking. Bye bye.